Good afternoon, everyone. It's a proud moment for me today to come back to my alma mater and deliver a lecture on pathophysiology, diagnosis, and treatment of knee pain. I bring warm greetings from AIIMS BB Nagar. So in this lecture, I would like to talk about the following things: functional anatomy of the knee, a rational approach to knee pain, where I'll be trying to explain to you the importance of history taking, physical examination, and imaging, as they were helpful. Common painful conditions of the knee, the pain generators or the sources of pain, like we like to call it. And I would like to summarize all of this with an algorithmic approach to knee pain. There is a lecture by Dr. Rajneesh on the anatomy of the knee, so I will not take a lot of time with this. But I'll be brief with the functional anatomy. So as we all know, it is the largest joint in the body in terms of articular surface and joint volume. So the knee is capable of amazingly complex movements that encompass highly coordinated flexion and extension. Even the simplest movements of the knee involve an elegantly coordinated rolling and gliding movement of the femur on the tibia. So for our ease, I would like to divide the knee joint into two: a femoral tibial joint and a femoropatellar joint. So the femoral tibial joint is made up of articulation of the femur and tibia, as you can see in the picture. Interposed between the two bones are two fibrocartilaginous structures known as the medial and lateral menisci. The menisci serve to transmit the forces placed on the femur across the joint onto the tibia. They possess a property of plasticity in that they are able to change their shape in response to the variable forces that are placed on the joint. The medial and lateral menisci are relatively avascular but receive bulk of their nourishment from the synovial fluid, which means that little potential for healing exists when these important structures are traumatized. So this is the sagittal view. You can see the femoropatellar. Can I have a pointer? Yes. So this is the femoropatellar joint. Patella is basically a large sesamoid bone embedded in the quadriceps tendon here to improve the mechanical advantage of the quadriceps muscle. The medial and lateral articular surfaces of the sesamoid interface with the articular groove on the femur here. In extension, only the superior pole of the patella is in contact with the articular surface of the femur, leaving the inferior pole free. As the knee flexes, the patella is drawn superiorly into the trochlear groove of the femur. Then now coming to the ligaments. So the main ligaments of the knee are the anterior and posterior cruciate ligaments here, which provide much of the anteroposterior stability to the knee joint, and the medial and lateral collateral ligaments, which provide much of the varus and the valgus stability. All these ligaments also help prevent excessive rotation of the tibia in either direction. A number of secondary ligaments also add further stability to this inherently unstable joint. So what is a rational approach to knee pain? It is the starting point. When a patient comes to the clinic with knee pain, the starting point for any clinician is to obtain a targeted history and perform a targeted physical examination of the affected knee or knees. So these are the order in which, or these are the type of questions I would like to ask my patient. Where is the pain? How did it begin? What were you doing at the time? Did you experience any grinding or locking or catching or giving away of the knee? Are there any positions which make your knee more or less comfortable? What is the quality of your pain? Sharp, shooting, dull, etc. Have you tried anything to help with the pain? And any other important questions are, have you ever had surgery on the knee? Any hip or ankle pain, a joint above and a joint below? So this, why I am asking this history is, pain at the joint line can tell me about any collateral ligament or meniscal problem. Pain at the tibial tuberosity in a young patient, this is a specific diagnostic point for Osgood-Schlattler's syndrome. Anterior knee pain could be patellofemoral disorder. Pain over the medial tibial plateau approximately 2 inches below the joint line is a pes anserine bursitis. I will show you in images. Pain and swelling in the posterior knee is a classic Baker's cyst. So when did the pain begin? Ligamentum injury, a ligament injury is a mechanism, is a twisting of the knee or a deceleration injury. Immediate symptoms are swelling and pain. Patient tell you that they hear a pop at the time of the injury. Meniscal injuries are same with twisting or deceleration. There is no swelling immediately. Immediately swelling may not be there and there is no popping sensation. Older patient may not even recall an inciting traumatic event. Chronic onset are our classic osteoarthritis, a disease of degeneration, patellofemoral syndrome, Osgood-Schindler's, and fractures will obviously have a history of trauma. So the grinding is with respect to osteoarthritis. Giving away is generally with ligamentous injuries. Locking and catching is with meniscal injuries. So targeting any positions which make the knee comfortable or not is to target the diagnosis of patellofemoral syndrome. Classically, patients report pain with prolonged knee flexion and pain relief with knee extension. So this is the movie theater sign. To relieve the pain, the patient will report extending the leg into the aisle while sitting in a flight. So the other things I would like to ask a patient in a history is whether the issue is acute or chronic, age of the patient, history of any trauma, any fever associated with knee joint, pain in any other joints, polyarthralgia, any rash, this is rare but important, and any other constitutional symptoms which could give a diagnosis of a malignancy. So the acute onset of knee pain in the absence of trauma is a cause of concern for the pain physician. Acute knee pain and fever should be considered a dangerous combination. Although some acute febrile illnesses such as streptococcal pharyngitis may have a large joint arthralgia as a part of constellation of symptoms, we must rule out the septic knee joint, collagen vascular diseases, and Lyme disease before assuming that the fever and pain are unrelated. So this is why I said age of the patient is important, because certain things come only during childhood, like a juvenile chronic arthritis. There is most commonly the meniscus are torn in adolescent age group. Adulthood, we get inflammatory arthropathies, and older age is the classic osteoarthritis. These are the intra-articular causes. Same for periarticular and referred pains. So this is the rash I was talking to you about. Although uncommon, Lyme disease after a tick bite can cause significant knee pain. This condition is usually associated with a specific rash known as erythema migrans, which is a result of infection with Borrelia burgdorferi. Failure to accurately diagnose and treat this uncommon condition of knee pain can result in permanent knee damage. So examination, once my history is over, I come to examination. I first inspect the patient in sitting and standing. I try to make him walk so that I see his gait, whether it is any antalgic gait, a component is present or not. There is something called a Q angle, usually measured by orthopedicians. It is a quadriceps angle around 15 to 30 degrees. And see for any obvious swelling or scar of previous surgery on the knee. Palpating usually starts from local rise of temperature, tenderness, this is common, and patellar tracking, any crepitus. Patellar tap and ballotment is done for effusions of the joint. This is how a ballotment is done, where from the quadriceps tendon, the muscle is squeezed, brought to the knee, and then checked for movement of fluid. The fluid moves from one bursa to the other. So next step is to test the integrity of ligaments and the meniscus. So there are 4 or 5 tests here. Each ligament may have multiple tests. I will not go into details. We are not orthopedicians, but I'll try to tell at least one for each. So valgus stress test is performed to test the integrity of medial collateral ligament. The examiner will force the lower leg away from the midline while observing for widening of the medial joint compartment and pain. Next is a varus stress test, where he does the opposite. He pulls the leg towards the midline. This is for the lateral collateral ligament. It is not usually common. Medial collateral ligament injuries are more common. Then this is the most common test done for anterior cruciate ligament integrity, anterior draw test. Another one, Latchman test, is also done, but this is the first thing we do. The patient is lying supine with knee flexed to around 35-40 degrees. The examiner then grasps the affected leg below the knee with both hands and pulls the leg forward while stabilizing the foot. The test is considered positive if more than 5 mm of anterior motion is seen. Similar test where we push the foot back for this is called a posterior draw test, test the integrity of the posterior cruciate ligament. So this test is again considered positive if more than 5 mm of posterior motion is seen. So this is a McMurray's test for the diagnosis of a torn meniscus. It can provide the clinician with useful information as to whether a torn medial or lateral meniscus is responsible for the patient's pain. It is considered positive or a meniscus is torn if the examiner appreciates a palpable or auditory click while rotating or extending the knee. Rotating and extending the knee, I'm sorry. So why we focus on history and examination is because a professor in this very hospital once taught me that 81% of our diagnosis comes from history, 9% comes from examination, 9% from investigations. So this is 99. The rest 1%, don't tell anyone outside this room, is by luck. So the common painful conditions of the knee, why we need to know this is because we need to know the sources of pain. What are the things which can generate pain in a knee? So your bones, ligaments, bursae are usually the common things. So the initial physical examination of the knee guides the clinician in narrowing his or her differential diagnosis and helps to suggest which specialized physical examination maneuvers and laboratory and radiographic testing will aid in confirmation of the cause of the patient's knee pain. For the clinician to make best use of the initial information gleaned from the physical examination, a grouping of the common causes is exceedingly helpful. Although this list is not exclusive, frequent overlapping and multifactorial nature is present, but still it is by no means comprehensive, but it still aids the physician in diagnosing and narrowing down the potential sources of pathology. So if the pain arises from the bone or a joint space pathology, these are the causes it could be, the causes which could happen. There could be a fracture, a primary bone tumor, a synovial tissue tumor, any localized arthritis, osteophytes, hemarthrosis after a minor trauma or repeated trauma, any intra-articular foreign body, like I said, Osgood-Schindler's disease in the children, and patellofemoral pain syndrome. So if there is knee pain from periarticular pathology, then it could be bursitis, inflammation or infection of the bursa, tendinitis. Adhesive capsulitis is usually seen in the shoulder, but sometimes, yes, even in the knee. Muscle strains and sprains after minor sports injuries. And coming from systemic diseases, our causes are rheumatoid arthritis, collagen vascular diseases, gout, any other crystal arthropathies, and Charcot's neuropathic arthritis. Coming from, there can be knee pain which is sympathetically mediated as well. So this is from reflex sympathetic dystrophy or causalgia. From any other body areas, like I said, always examine a joint above and a joint below. So there could be referred pain from the lumbar spine. So any radiculopathy, spondylosis, fibromyalgia, or retroperitoneal tumors. So these are the causes, these are all the things which could cause knee pain when you have a patient with a painful knee in the OPD. So coming to the most common, I will not go into too much detail, but coming to the most common knee pathology which we see in our practice, osteoarthritis knee. So I will directly jump to the X-ray findings. The hallmark is a joint space narrowing, usually asymmetric, but could be more predominance to the medial component. Less than 3 mm narrowing on weight-bearing knee radiographs is considered a finding of absolute joint space narrowing, with a normal joint space generally is more than 5 mm. Weight-bearing radiographs will demonstrate more joint space narrowing than non-weight-bearing, that is obvious. The other X-ray findings are subchondral sclerosis, marginal osteophytes, subchondral cysts, and altered shape of femoral condyles and tibial plateau. So the MRI findings on the same ONE will be effusions and synovial thickening or synovitis, subchondral bone marrow edema, cartilaginous defects, bursitis or iliotibial band syndrome. So the grading for ONE is from 0 to 4, 0 being definite absence of X-ray changes, 1 being doubtful joint space narrowing, 2 with osteophytes and possible joint space narrowing, moderate with multiple osteophytes, definite joint narrowing, and some sclerosis. And severe is almost bone on bone with large osteophytes, marked narrowing of joint spaces. So this is the range of the X-ray. So this is the joint space, minimally narrowed here, and this is almost bone on bone, so this is grade 4. Next, coming to the bursitis, all the different types of bursa which are present around the knee. So the first we start with suprapatellar bursitis. There are around 4 or 5 important bursa around the knee. So suprapatellar bursitis is present above the, extends superiorly from beneath the patella, underneath the quadriceps femoris muscle. So this is your patella, this is your femur, and this is the suprapatellar bursa with a collection of fluid in this patient. The patient with suprapatellar bursitis frequently has pain in the anterior knee above the patella, which can radiate superiorly into the distal anterior thigh. Often the patient is unable to kneel or walk down the stairs. So this is the location, and that is how an injection is given. Patient is lying supine with knee slightly flexed with a pillow below the knee. The superior margin of the medial patella is identified. Just above the point, the needle is inserted horizontally to slide just beneath the quadriceps tendon here. Then there is a prepatellar bursitis. Prepatellar is superficial present. This is the patella. This is a collection just above the patella. It is vulnerable to injury from both acute trauma and repeated microtrauma. A prepatellar bursa lies between the subcutaneous tissues and the patella here. And it results from jobs that require crawling on the knees, such as laying carpets and scrubbing floors. Hence, the other name for it is a housemaid's knee. So we see here, above the patella, we have a prepatellar bursa. The center of the patella is identified at the midpoint. Just above this point, a needle is inserted horizontally, and a local anesthetic or with steroid can be injected there. If the needle strikes the patella, it is withdrawn slightly and redirected superficially. Next, there are two infrapatellar bursas. One is superficial and deep. This one is superficial. It lies between the subcutaneous tissue and the upper part of ligamentum patellae. The patient with superficial infrapatellar bursitis frequently has pain and swelling in the anterior knee over the patella that can radiate superiorly and inferiorly in the area surrounding the knee. So above this is the superficial infrapatellar. Below the patella, so infrapatellar. Above this, so superficial. When it is below it, it is called deep infrapatellar. So same, the center of the lower pole is, so this is the fluid collection. The center of the lower pole of the patella is identified somewhere here. This is the patella. This is the lower pole of the patella. Just below this point, a needle is inserted at 45 degrees angle to slide subcutaneously into the superficial infrapatellar bursa. So this was the pes anserine bursa I was talking about. This lies beneath the pes anserine tendon, which is the insertional tendon of the three muscles, sartorius, gracilis, and semitendinous. I'm confident I did not know this name when I was doing anatomy here. And this is present in the medial side of the tibia. The pain of pes anserine bursitis is constant and characterized as aching pain. So care should be taken to not injure the medial collateral ligament while treating the pes anserine bursitis. The point distal to the medial joint space at which the pes anserine tendon attaches to the tibia is the location of the bursa. Is usually identified with point tenderness at that spot. This is what I was talking about in the examination part. Same, the needle is inserted at a 45-degree angle through the skin and the subcutaneous tissues. Next is the last one, the deep infrapatellar bursa. It lies between the ligamentum patellae and the tibia. Patient with this has pain in the anterior knee below the patella that can radiate inferiorly into the area surrounding the knee. Coming to the cyst in the posterior part of the knee in the popliteal fossa. Patients with Baker's cyst have a feeling of fullness behind the knee. Often they notice a lump behind the knee that becomes more apparent when they flex the knee. This cyst may continue to enlarge. It can disrupt, and the fluid containing sac can be dispersed into the surrounding tissues. Occasionally, the dissection may be so significant as to cause a lower extremity compartment syndrome. Patients with rheumatoid arthritis are prone to this phenomenon. The pain associated with dissection into the calf may be confused with thrombophlebitis and inappropriately treated with anticoagulants as well. Care should be taken while injecting into the bursa because there are vessels here, popliteal or artery and vein, and our sciatic nerve, already branched by this point. Next, coming to a rare cause of knee pain, quadriceps expansion syndrome. It is an uncommon cause. It is characterized by pain at the superior pole of the patella. So it is usually a result of overuse or misuse of the knee joint, usually in athletes. in running marathons. This is an MRI image where the top two are partial tears. This is the point where the quadriceps is torn, if you can appreciate. And the C and D, the bottom two, are complete tears. This is the part where it is torn completely. This is on ultrasound. This is the patella. This is the tendon, quadriceps tendon, which is torn, and there is a blood-filled cavity formed between the tear. Now, I will try to accumulate all of this in a algorithm. So again, starting with history and mechanism of injury, physical examination, whether there is a swelling or a traumatic injury. If there is a swelling, come back here. So swelling, whether it is intra-articular or extra-articular, is the swelling extra-articular, it could be bursitis or Baker's cyst. If it is intra-articular, it could be effusion or no. Intra-articular could be arthrosis, any crystals, any infection like septic arthritis or non-infectious. If it is not, then it could be effusions, moderate to large or small, both treated with arthrocentesis. Coming to traumatic, if there is a swelling, come here. So if there is no swelling, are the Ottawa rules satisfied? Ottawa rules are nothing but whether patient is able to walk 4 steps, 2 steps on each leg, and a few other things. So if those rules are satisfied, patient is able to walk, then we get an X-ray done. If it is positive, you know whether there is a fracture of femur, tibia, or patella. Remember, this was traumatic injury. So if the rules are not satisfied, patient is unable to walk, then you try to find the location of the pain, whether it is in the anterior component, like I said, Latchman test for ACL here, medial component, valgus test, lateral component, posterior component. So if there is no swelling, and then you check for any rheumatology history in the family or in the patient, or then you check whether OA clinical criteria for osteoarthritis are met. If there is rheumatology positive, then you send for labs, you get a diagnosis. Basically, you have to know where the location of the pain is, and the tests are accordingly. So this is an algorithmic approach. Thank you for your attention.
Thank you for the informative lecture, sir. I request Dr. Padmavati Madam to present the memento to Anish Waghray, sir.